Good afternoon to the audience. I'll be presenting on traumatic pediatric cataract.
One second. We cannot see it on the screen here. Yeah, it's only there. It's not here. Okay. Yeah, I think you can start. It will come after 30 seconds. Doesn't matter. Yeah.
So I would like to declare no financial interest. So coming to the introduction, so the trauma can be mainly, as we all know, can be divided into a closed globe or the open globe. The blunt trauma cataracts, that is the closed globe cataracts, are usually stellate or rosette shaped, and the penetrating trauma cataract are usually progressive cortical opacification, the speed of which can depend upon whether the lens capsule is intact or it is ruptured. So, what is important in assessing pediatric traumatic cataract is history taking. Although children are poor history givers, but still, if you want to know what they have got the trauma and how long was the trauma, whether the trauma is a trivial trauma or a significant trauma, because sometimes the children will present with a history of very trivial trauma, which is unlikely to cause a cataract. Maybe the cataract was present long before, and just because of the trivial trauma, they have come up for the examination. So in these cases, you have to really take into mind there might be a dense amblyopia behind. So you have to counsel that beforehand. Coming to the examination, before dilatation, you have to check the BCVA, fixation preference, pupillary reflex, IOP, and iris for any defect. Small metallic foreign bodies sometimes produce an iris defect, and through the zonules can lodge into the retina. So you have to be very careful for that. So sometimes that is more so because most of us receive the patients after the optometrist has seen and dilated, and we receive the patients dilated. So you have to tell the optometrist that before dilatation, just let us see before dilatation, so that these fine points should not be missed. And after dilatation, lens examination and zonules, posterior segment examination, and biometry if you planning surgery, and anterior segment OCT, and if the child is cooperative enough, for ultrasound biomicroscopy. So, what are the challenges? So, the pediatric eye itself is a big challenge. We know that a pediatric eye is not a miniature adult eye. So, we have to take that into account, and the progress should be accordingly. So, as I was saying, mode of trauma. So, how much is the trauma amount of trauma matching with the amount of cataract? Now, sometimes you'll give a history that the sibling has put in scratched with the nail or something like that, and you see a total cataract. Well, a scratch with the nail will probably not produce a total cataract. So maybe the cataract was less initially, maybe it has progressed to such levels. So expect a dense amblyopia. Pre-op assessment. So not only the ocular but systemic pre-op assessments are also very important, because you are anticipating the surgery under general anesthesia. Surgical challenges, sometimes not everything can be assessed pre-op, so you have to keep in mind that you may face hurdles during the surgery. So be prepared, and sometimes maybe even keep the retinal surgeon in hand in case you need him or her. So the general principles are, usually the anesthesia is almost always general anesthesia unless the child is an adolescent and can cooperate. So the incisions are usually clear corneal. Well, when we are implanting acrylic foldable IOL, sometimes economic constraints can lead us with the PMMA IOL, so can opt for scleral incisions in those. So anterior capsule is a manual capsular access. If the anterior capsule is compromised, you can go for vitrector access. And hydrodissection, if you see a total cataract or if you don't know the status of the posterior capsule, it's better to avoid hydrodissection. Posterior capsule management, if you feel that the child will not cooperate within a year or two's time, when the child will develop a posterior capsule opacity, you have to do a posterior capsulotomy, provided there is enough capsule, and you have to assess that. And the IOL ideally should be in the bag, or a 3-piece IOL in sulcus, preferably with an optic capture, and also expect a higher inflammation. So I'll be discussing one single case due to time constraints. So this is a 4-year-old child who had injury with a stone 9 months prior. Primary corneal wound repair was done elsewhere, presented to us with a corneal scar and a total cataract. So this is the examination. The right eye was the eye. So it was PL plus, PR accurate, central linear scar, anterior segment quiet, posterior synechiae was present, total cataract. IOP in Goldman was 14. The fundus had no view. Other eye was normal, so the right eye USG showed normal. So we went ahead and planned the cataract surgery. So here we are making a small incision with the MVR blade. And then we are putting some dilute epinephrine. So, but there is very poor dilatation due to the posterior synechiae. You can see the central linear corneal scar. Even after visco, the pupil doesn't dilate much. So we went ahead and did some synecholysis. And there is a little bit of bleeding, but still there is not adequate pupillary dilatation. So we went ahead and put some iris hooks. And here you can see that the anterior capsule and the posterior capsule are adhered. They are very thick. Even the vitrector was not able to cut it very efficiently. So we had to make small snips with the micro scissors, and then the vitrector could cut it easily. So here we are putting the 3-piece acrylic IOL, and at last was the nose. Anterior vitrectomy was limited. Anterior vitrectomy was done, and suturing of the ports done, and last the visco wash. So checking all the ports, they are not leaking at all. So the summary is every traumatic eye is different. You have to assess proper pre-op assessment and still expect surprises on the way. So each eye requires a tailor-made approach, means involved other subspecialty. A trauma may have caused an orbital floor fracture, so a plastic intervention might be needed. A foreign body might be lodged in the retina, so a retinal colleague, you might need to call them, and also needs innovative steps to avert difficulties. Thank you.
Thank you for that crisp presentation. You mentioned so many investigations in your first slide. UBM, AIOCT, and all these things. What is the use of all these things when the pupil doesn't dilate?
Yes, sir. Most of the time, all the investigations we will not be able to do because the child doesn't cooperate well. So these ideal scenarios, if all of these can be done, is okay. But then
I think ultrasound is what you would require mainly because of the posterior segment, and that can tell you whether the posterior capsule is ruptured or not.
Yes.
So with one investigation, you would know both these things. Other anesthesia investigations, okay, I mean, you're having a lot of machine works, but it's just your clinical skills what matter there, and what best you can do without subjecting the patient. Because if the patient has a globe injury, okay, then obviously the repair is first, and the timing of the cataract extraction is very important. So whether you would do it as a primary procedure or you would wait for the eye to quieten.
If the anterior capsule is ruptured, what I usually do is when the lens matter is coming out, so I wash up all the lens matter that is coming out, and then can keep a phakic, and later when the eye quietens down, you can do a biometry and put a IOL and that secondary IOL.
Yeah, biometry is again an issue because you have corneal scarring in a penetrating eye injury, and obviously it might not give a good result even if you do a secondary IOL. But yes, the indication for removal is if you have lens matter in your anterior chamber, that is you have to remove. Otherwise, I think probably a secondary procedure would be much better. And these eyes are much prone to a lot of inflammation.
Yes, sir.
So if we can avoid that sulcus area, probably that would be better wherever avoidable. But as you showed, I mean, it's such a fibrotic capsule presented after 9 months. Probably there is no other way, I mean, you could do it.
Thank you, sir.
So any other comments? Any questions? Yeah.
Yeah, that is yeah.
Mike.
Yeah.
It's very important. Sometimes the main suture removal will take time, isn't it? So even then, you can still give glasses, whatever is possible, and don't wait for all the sutures to be removed to give glasses because that will take a long time, isn't it?
What I give 10-0 vicryl sutures for the side port and main port. So removal is not.
Corneal tear.
Oh, yeah, that is,
that big suture.
yeah. So actually, this patient presented when they presented, the corneal sutures were already removed, so only the scar was present.